जो हम टॉपिक डिस्कस करने जा रहे हैं वो है मायोकार्डाइटिस। व्हाट इज़ मायोकार्डाइटिस? मींस मायो मींस इट्स अ myocyte. Myocyte is a cell of myocardium. Myocardium is the innermost, it is the middle layer of heart. Middle layer of heart. And myocarditis, itis means it's a inflammation, means it's a inflammation of inflammation of middle layer of heart is called मायोकार्डाइटिस। सो इस लेक्चर में जो है हम डिस्कस करेंगे etiology and risk factors, sign and symptoms, diagnosis and the treatment of myocarditis. So let's start. First of all, we will discuss about the epidemiology, about the data, and the first important thing is the exact incidence is unknown, and 1 to 5% mostly viral infection like Coxsackie virus and A and B Coxsackie most commonly involved in this. We will discuss about the in etiology, and often occur in young patients. More the average age is 40 years. So these important points you need to remember, because most of the clinical scenarios these points are mentioned. And in 10% of the sudden death in young adults, myocarditis is diagnosed in the post-mortem examination. Sudden death is due to arrhythmias. Why? Because when myocardium is not properly work, so there will be cardiac arrhythmia which lead to the death of the patient. So this one is the inflammation of the हार्ट मसल्स इज कॉल्ड. सो यू कैन सी इस पिक्चर में जो है वो हार्ट की जो इन जो मिडल लेयर है, सो इसकी इन्फ्लामेशन हुई है. ठीक है. सो दिस इज़ द इन्फ्लामेशन ऑफ हार्ट इज कॉल्ड मायोकार्डाइटिस. नेक्स्ट, इस पिक्चर में जो है दिस इज़ द हार्ट नॉर्मल हार्ट मसल्स and normal myocardium, and in this picture in myocarditis you can see there is inflamed myocardium, there is thick and swollen, because if there is inflammation definitely there will be edema, there will be swelling of the myocytes, and also there is inflammatory immune cells infiltration into the cardiac muscles. And now we will discuss about the etiology of the myocarditis. Most commonly it's related to infectious. So this is important point. Most commonly myocarditis is infectious. So what are the causative agents? Viral. Viral are the most commonly implicated. Coxsackie virus B1, 2, 3 and 5 are the most commonly involved. These are the family of picornavirus. Parvovirus B19, which also cause aplastic anemia. Aplastic anemia. And also it cause fifth disease. Fifth disease. Erythema infectiosum. It also cause erythema infectiosum. And human herpes virus 6, adenovirus, hepatitis C virus, HIV virus, and HIV virus, Epstein-Barr virus, cytomegalovirus, ecovirus, influenza virus, all of these viruses are involved in the myocarditis. And above in this mentioned virus, Epstein-Barr virus also cause infectious mononucleosis, also called kissing disease. And then we will discuss about the bacterial causes. So bacterial, there is beta hemolytic streptococcus group A, which cause the acute fever, and corynebacterium diphtheria, which cause the diphtheria, and diphtheria toxin, which this toxin attack on the myocardium and lead to the myocarditis, and Borrelia burgdorferi, which lead to the borreliosis, and also it cause Lyme disease. Lyme disease is also caused by Borrelia burgdorferi bacteria. And Mycobacterium, definitely it will cause tuberculosis. And Mycoplasma, fungal infection. What are the fungal infection? Is candidiasis and aspergillosis. इन कौन से लोगों में जो है ये फंगल इन्फेक्शन मोस्ट कॉमनली हो सकता है? मोस्ट कॉमनली अम्यूनो कंप्रोमाइज़, क्योंकि उन लोगों में इम्यूनिटी नहीं होती इसको फाइट करने के लिए अगेंस्ट द फंगल इन्फेक्शन, तो उनमें मोस्ट कॉमनली होता है। और वो लोग जो कि स्टीरॉयड लेते हैं, जो कि एज अ ड्रग स्टीरॉयड लेते हैं, उनमें इम्यून सिस्टम कंप्रेस होता है, जिसकी वजह से मोस्ट कॉमनली इन्फेक्शन होता है। नेक्स्ट, प्रोटोजो प्रोटोजो चागर डिजीज़। चागर डिजीज़ most commonly is caused by trypanosoma cruzi. And in this condition, if we see there is a mastigote within the heart muscles, what we can see, a mastigotes in heart muscles. So these are the intracellular stage of trypanosoma. So due to this, there will be necrosis of heart muscles. And most commonly, this is most commonly in South America. If there is any if there is clinical scenario and they mention South Africa, America, and also mention there is in options they mention trypanosoma cruzi and any Chagas disease, so you can choose that point, okay. And also there is parasitic infection, most commonly trichinella, which is the intestinal, this is the intestinal roundworm. And most commonly they can involve the heart and echinosis. And this is the infectious causes in which we mention viral and bacterial. अब हम डिस्कस करेंगे नॉन इन्फेक्शियस काजेज, मोस्ट कॉमनली connective tissue disease like SLE. In SLE there will be immune system, so immune system, there is over attack of the immune system can attack the myocardium. So there is high immune system activity, so which can attack the heart muscle. And next there will be vasculitis syndrome like Kawasaki disease, and also is a immune mediated, there is overactivity of the immune system. And also toxic myocarditis, radiation therapy, medication like sulfonamides, and due to any drug reaction. And that's why there will be eosinophil into the blood vessels in myocarditis, and chemotherapy in anthracyclines, alcohol, cocaine. And also there is one kind of giant cell myocarditis. There is inflammation of the heart from unknown cause, and in this condition we can see there is macrophages fuse and form giant cells. Like there is small macrophages, so they fuse, so they form like this big cell. This is called giant cell myocarditis. So अब हमने डिस्कस की इसकी etiology. Now अब हम डिस्कस करेंगे clinical features of myocarditis. Most commonly it's asymptomatic but may range from acute fulminant cases to chronically active and persistent myocarditis. If proceed 1 to 2 week, flu-like symptoms like there will be fever, arthralgia, myalgia, upper respiratory tract infection indicate the post-viral, because these are the symptoms which mostly related to the viral infection like fever, arthralgia, myalgia, and upper respiratory tract infection. In infants and young children, there will be poor feeding, irritability, respiratory distress, and failure to thrive, fatigue, weakness, dyspnea, nausea, vomiting. And definitely there will be next thing, most important thing is the cardiac arrhythmias. Why there is cardiac arrhythmia? Because the conduction system of the heart is disturbed due to inflamed myocardium, inflamed tissue. There is no proper movement of the eyes and no movement of the action potential. Definitely there will be cardiac arrhythmias, which may be sinus tachyarrhythmia, ventricular extrasystole with palpitation or syncope, definitely there is excess systole which lead to syncope because there is no proper pumping of the blood toward the brain. So which excess systole lead to decreased cardiac output. This decreased cardiac output lead to the syncope and also heart block with bradyarrhythmia. And chest pain indicates that there is pericardial involvement, means there is perimyocarditis, means uh, this is myocardium. Myocardium is the middle layer, and above that there is pericarditis. Green one is pericarditis, and red one is myocarditis, and black is endomyocarditis, endocarditis, endocardium, endocardium. Endocardium is the inner layer of heart. So myocardium, due to persistent inflammation of the myocardium, there is above lying layer which is called pericardium. So it's also involve the pericardium, so which lead to the condition which called perimyocarditis, means there is persistent inflammation of the myocardium which lead to the inflammation of the pericardium, which this condition is called perimyocarditis. Acute decompensative congestive heart failure with dilated cardiomyopathy. Definitely there is so due to persistent inflammation of the myocardium, there will be myocardium become weak. So due to weakness of this heart, so if there is a normal chamber, like this is a normal ventricle, so due to weakness it become like this, like there is dilatation. Why dilatation? Because there is weakness of the wall of the of the muscles of the myocardium. And also cardiogenic shock, definitely if there is no proper if there is dilatation, there is no applying of the Frank Starling law, and also there is no proper pumping of the heart, definitely lead to the cardiogenic shock, auscultation finding, there will be a systolic murmur, heart failure, and S3 S4 gallop, means there is S3 and S4 sound we can hear, and also lead to the pericarditis. And pericarditis, there is friction rub, means so pericardium is the outermost layer. So if this is the chest wall, chest wall, so this is the heart. So there will be friction between chest wall and the heart, and which can lead to the pericardial friction rub. So we can hear, and these are the clinical features we discuss in this lecture. And next we will discuss about the diagnostic points. So we will do 24-hour Holter monitoring by ECG. There will be sinus tachycardia, and also arrhythmia like atrial, ventricular ectopic beats, and complex ventricular arrhythmia, repolarization abnormality, T wave, ST wave segment changes, and most commonly we can see there is saddle shaped ST elevation, and also there is, most importantly, there is T wave inversion, and one important thing, ST shaped elevation, and second is T wave inversion we can see in myocarditis. And also possible ST segment elevation we already discussed. Heart block, maybe right bundle branch block, complete heart block, AV block. Rule out myocardium infarction. How can we rule out? This is an important point. Loss of R wave and pathological Q wave specifically to the myocardium infarction but not found in myocarditis, means there will be, if there will be MI, so there will be must no R wave and there will be Q wave. But in myocarditis there will be no these conditions, means there will be no R wave, and there will be R wave and there will be no Q wave. So this is the opposite to the myocardial infarction. pericardial effusion, definitely low voltage. And now next, this is the ECG. We can see there is T wave inversion, and also this is the saddle shaped ST elevation, and also there is T wave inversions. And in this echocardiography we can see this is the echo. There is inflamed valves. We can see there is inflamed valve. And next diagnostic step we can do, there is chest x-ray and CT scan, in which there is, if we see in chest x-ray and CT scan, there will be cardiomegaly, pulmonary congestion. Why pulmonary congestion? Due to the heart failure. And also there is pleural effusion. Echocardiography findings unremarkable ventricle dilatation, diffuse hypokinesia, means there is no proper strength of the wall of the myocardium, reduce ejection fraction and impair contractility, and also there is motion abnormalities. Pericardial effusion, localized and circumferential fluid surrounding the ventricles, occlusion of the other etiology of the heart failure, and also heart defect we can see through echocardiography. And in this picture you can clearly see there is edema of the heart walls, so there is swelling, and hyperemia means there is high blood flow to that area, and also there is necrosis and scar formation in this area. You already see there is necrosis and scar formation in this area. And ultimate diagnosis we can do through biopsy, but it's very dangerous. Definitely, how can we take biopsy from heart, directly from heart, is definitely dangerous. So how can we do biopsy? Via cardiac catheterization of the left heart and MRI supported biopsy. So what are the indication, which is the important thing we need to know? New onset of the heart failure and severe arrhythmias and resistance to treatment. If there is heart failure and severe arrhythmia, like arrhythmia is not controllable by drugs, so we will do biopsy. Only performed if previous diagnostics are inclusion, and definitive diagnosis of myocarditis might influence the treatment. What are the results if we do? If we do biopsy, we will check the viral DNA and RNA, and then we give definitive diagnosis of that virus and RNA. And if we do immunohistochemical detection of inflammation, then there will be focal necrosis like this. This is the focal necrotic area, and also you can see this one is lymphocytic infiltration. So lymphocytic infiltration, so there will be lymphocytic infiltration, and often has a viral. If there is, this is the important point, if there is a lymphocytic infiltration, this means this is a viral cause. So in immunohistochemical detection we mostly see there is, if there is a lymphocytic infiltration, so it will be most commonly viral cause. So try to remember this point. Okay, next we will discuss about the treatment. So first of all, sportive treatment like inpatient surveillance, cardiac monitoring by ECG. How can we do? By ECG. And also oxygen administration, management of the fluid status, rest, avoid physical activity, because we have to reduce the activity of the heart, and we have to reduce the pump pumping activity of the heart. Analgesic drugs if there is pain, and causative treatment, if antibiotic therapy for the bacterial myocarditis we already discussed. If there is beta streptococci, corynebacterium, and borrelia burgdorferi, then definitely we will do antibiotics. If there is antimycotic like fungal infection, then we will give fluconazole, amphotericin B for the fungal infection. And also treatment of the complication, if there is congestive heart failure, management of the fluid accumulation with diuretics, beta blockers, ACE inhibitors, and treatment of cardiac arrhythmia, amiodarone. We give amiodarone, but amiodarone, there is adverse effect of the amiodarone. What is the most common effect? Is called pulmonary fibrosis. So next, heart transplant. If there is Chagas disease and other conditions, we will do heart transplant. This is the definitive diagnosis if it's not treatable. Next, we discuss about the complications. If the uh, myocarditis persists, like if lead to the chronicity, definitely it lead to the dilated myocarditis, cardiomyopathy. Why? Because there will be weakness of the heart valves, so which lead to the dilatation, and also concurrent pericarditis, which lead to perimyocarditis, may lead to the cardiac tamponade. Why cardiac tamponade? Means if this is the heart wall and this is the outer covering, so this area is the weak, so this blood leak out like this, so there will be accumulation of the blood in pericardial fluid. So blood accumulation in pericardial space, sorry, in pericardial space is called cardiac tamponade, associated with large pericardial effusion, heart failure, and the sudden cardiac death due to ventricular tachyarrhythmia and fibrillation, most commonly seen in adults less than 40 years of age. Acute and persistent arrhythmias, arterioventricular block. Why arterioventricular block? Because there is no proper conduction system of the heart, which lead to the cardiac blockage, and intracardiac thrombi formation, which can result in systemic embolization. Why there is intracardiac emboli formation? Because if there is arrhythmia in this condition, if this is the heart, and heart there in arrhythmia there is immature contraction of the heart valve, so means there is more time for blood to stay, so blood stay for more time in the different chambers of the heart. If blood stay for more time, because due to persistent arrhythmia, so if blood stay for more time, which undergo coagulate, so which lead to the intracardiac thrombi formation, which can occlude in the brain vessels, lead to the stroke. If it occlude the coronary artery, it lead to the myocardium infarction. If it blocks the uh, pulmonary circulation, and also can block the mesenteric ischemia. So these are the few complications we discuss about in myocarditis. I hope you understand this topic, and if you really understand, please like, subscribe my channel. Thank you so much.